Today I'll be speaking about the pain interview, and the thought was that this would be the opening conversation in all our sequential didactics. I subtitle the talk, Stop Trying to Cure Me and Start Listening. This is courtesy of a nurse, and I'm blanking on her name, from Bournemouth, England, Eloise Carr, Dr. Eloise Carr, a nurse researcher, who was doing a user survey, end user survey of people who were going to be using a pain clinic that was going to be opened up in that community. And they did a lot of focus groups. And the common theme that was heard, and I remember her reporting this and it struck me, was what the patients who were reporting for chronic pain care were saying. What they wished this clinic would do would be to stop trying to cure me and start listening. And I was really struck, since that's much of what we do in the interview. Don't forget, the interview is an opportunity to ask questions and then listen to the answers. So that's the thematic development that we're going to follow today. So the only disclosure is we do have some funding through the REMS programs, through the COPE program that Dr. Sullivan, the research project that he's leading in terms of education there. Objectives today are to be able to elicit a correct biopsychosocial chronic pain diagnosis. In an interview, we listen to the patient experience, and again, reinforce those who are regular attendees understand that the problem in chronic pain is often the impact of pain on the patient's experience, and that this is usually much more complex than any simple nociceptive pathways that we identify. And then thirdly, to establish trust with our patient and engagement with the patient, since this is the key to the initiation of successful chronic pain treatment. So we have two of our students in the room, Bree and Beth, who are just starting, and they remember, I'm sure, learning this in their Introduction to Clinical Medicine, old CARTS. Yes, you may remember that acronym. And that's obviously key questions that we need to know. When did the pain start? Its location, its duration, character of pain, alleviating and aggravating factors. And I've added attribution, because I think that's critically important, what the patient thinks is the cause of the pain, because oftentimes it may not match, and that's an important part of our dialogue, is to learn the mismatch and understand what happened there. The radiation, the temporal pattern, meaning what time of day it's worse or better, and that the other associated symptoms that are associated with the experience of pain. This is really the bio side of the biopsychosocial. And as physicians, osteopaths, nurse practitioners, and physicians' assistants who are working with the biological component, hence that's why our care is often sought, again, I want to stress that our job is to get the bio right. So this is very important that we understand that, and we obviously do spend time in these sessions reinforcing the need to understand the biology that may be preceding the experience. But courtesy of Dennis Turk, who's done a tremendous amount of research work as a clinical psychologist, we also know that there's a multidimensional burden that chronic pain places on our patients that are characterized by impairment in functional activities, impairment in social activities, then the economic consequences that are associated with the experience of chronic pain, and of course the impact on emotional functioning. And you can see listed here, and I won't read through them all, that the functional activities definitely affect work and household, or what we call life role, as well as avocational. Social consequences affect marital and family, intimacy, and we'll spend a bit of time on social isolation, which is highly linked to the experience of pain. The socioeconomic consequences. Pain is costly. It's $650 billion a year. This is several years back. Estimates of that cost, they include the lost productivity, but they don't include pediatric care. They don't include cost to the veterans and Department of Defense, and they don't include people who are institutionalized, particularly the elder who are receiving pain care in an institutional setting. And certainly the emotional impact is enormous: irritability, anxiety, depression, post-traumatic stress disorder, like what we talk about often. So this is part of our interview. We want to be able to capture this and learn about these impacts, critically important in order to properly assess the situation that our patients present with. So typical question, and I had the pleasure of working with incoming internal medicine interns today, and I always ask, what is the most disturbing issue about seeing a patient with chronic pain? And uniformly the answer is their pain is always 10 out of 10 or worse, because it really disarms us and pushes us back from the patient instead of understanding that. So if we look at what a 10 out of 10 or more means, I heard a record breaker. It was 14,000, I learned recently. A clinician told me the patient wrote on a 0 to 10, it was 14,000. But we'll just say 10 out of 10. We certainly need to rule out a new injury or illness, because people with chronic pain can get new stuff. Dr. Robinson, who's currently cruising the Mediterranean, he'll be back, I believe, end of next week. But Dr. Robinson reminds us, don't go brain dead on your chronic pain patients, which means they can always come in with something new and different. And I see Tiffany Zhang just after one of our physician assistants in the clinic identified early diagnosis and perhaps saved our patient's life who had multiple myeloma. And we were treating him for chronic thoracic back pain. But the pain was different. The patient said it was different. Her clinical judgment that this was different, and we got the workup done, and he had a malignant compression fracture, and which was his first presentation, and it would have been clearly delayed if we blew him off and said, "Oh, this is your chronic pain," and get lost. So you need to rule out new conditions. Excuse me. Also, oftentimes the pain intensity escalates by patient report when there are new psychological and situational stressors, anxiety, depression, a reoccurrence of a PTSD-like event. So being able to be attentive to high scores and recognize that there are other conditions that may trigger these super high scores is very important. Sometimes, but not often, high pain intensity is the patient seeking more drugs from us because they've run out of them early, and my pain is worse, I'm not getting enough medication, please up my dose. Misuse, abuse are frankly diverting. I think this is uncommon, and from my experience, I think our patients are quite savvy. If they disarm us and alarm us, they may anticipate that we're going to become more inquisitive about what's going on. So generally speaking, our patients who have been scamming me, and I learned about it well after the fact, have a nice, stable presentation. They know that I want their pain to be controlled, so they give me reasonable numbers and don't alarm me and put me off. But at least consider that as well. An undergraduate at your university journalism student, when we chatted about this in an honors course they have on pain, actually a very highly sought course with a waiting list for it because it's such an interesting topic, and interesting they have mostly non-pre-med students at that. And I just was asking the group, and he was a pre-journalism major, and he said maybe the patient is shouting for help. And I actually think that's the most brilliant response I've heard to date, because you raise the intensity of your voice when you shout, and you raise the intensity of your pain score when you're shouting for help. And Will Fordyce, one of the first clinical psychologists ever involved in the management of pain, came here at the University of Washington. Is a paraphrase from John Lozier, who said, as Bill Fordyce used to say, and I'm sure it's exactly the words, knowing John Lozier, you can get a pronoun out of place here. But the patient's report of chronic pain intensity is far more about that individual's capacity to manage their pain than it is about the stimulation of nociceptors. Hence, the pain intensity score is of interest. A recent publication by Dr. Sullivan and Ballantyne, just hitting the press, is calling for an elimination of pain intensity as a metric we even should follow. I can let Mark speak about that later as to how serious or whether this was merely a subject for discussion, knowing Mark. But there's been work on identifying other questions we should ask in the interview. This dates back to 2008. In order to have your research protocol submitted to the FDA and stating that your treatment is efficacious and effective, what are recommendations now from the impact group? And they called out pain intensity, of course, because we haven't gotten that bee out of our bonnet yet. But physical functioning, emotional functioning, and global rating of improvement of whatever treatment we're offering. So the key here again is that it's more than just about pain intensity, and there are clearly biopsychosocial matters. Hence, we've identified, and you living through this with our pain tracker and our insistence that we learn about these other things in our assessment in our interview, identify, of course, the pain intensity, but how much does pain interfere with function? How much does pain interfere with quality of life? How much does pain interfere with mood, sleep? And then identifying key risk factors that we will need to ascertain during the interview so we can begin to structure a treatment plan. And the risks that I've identified include, among others, how high is the opioid dose, and then the medical risks, i.e. sleep apnea syndromes, both obstructive and central, and psychosocial issues that will add a risk that's associated to our pain treatment, particularly when we're using opioids, and particularly when there's a call for benzodiazepines in our patient population. I also want to identify that the Washington State opioid rules, the opioid law, calls for documentation in your patient. So this is a care practice requirement if you're going to be prescribing opioids, and I think this should generalize to all patients we see with chronic pain, that we make a diagnosis. And I'll be talking at a future didactic about establishing the pain diagnosis and what might be the indications for chronic opioid. Now, is this going to fit into the headache, fibromyalgia, and low back pain constellation for which chronic opiates are never indicated? But what are the indications? Identifying comorbidities. Again, treatment effect on physical and psychosocial function, as well as pain, and a psychiatric status and an abuse risk. So this, again, is information that we acquire from our patients in the course of that interview. And our interviews often are short. We have the luxury here of a full hour for the interview and exam, discussion, and treatment planning. That's not enough. I have quite a reputation for not being able to stay on schedule because it's difficult to manage that. But many in a primary care setting will have 20 minutes or 30 minutes for a new patient to do this evaluation. And this is a daunting task. So we're going to kind of parse this down into how we can manage this. Another clear component that we want to be able to understand, and this partly is the attribution component that I've added, is that the patient's beliefs, and I put physicians here, but it should be corrected to pain care providers' beliefs, are not in sync. Going to the patient's beliefs, this is from Dawn Marcus's work. And I understand she's actually died in the past year. Phenomenal primary care provider, contributed enormously to the field. When I was searching an email address, I got her obituary, so that's sad news. But a major contributor for primary care folks. Her work is worth checking out if you're interested in increasing your own reading list. But patients actually believe that doctors don't think at all about pain as a problem. They don't ask about pain. They don't get enough time to talk to their clinician about pain, and that we agree with that. We get 6 minutes to talk about pain with our patients on several published studies in a primary care setting. Here's the pain intensity score. No one believes my pain is as bad as it is, and that's the shouting we hear. And surely we would much rather treat a nice, simple medical illness, even a complex medical illness, rather than managing pain, because we don't know much about how to manage that. On survey data coming from Breivik's work, lots of negative attitudes toward treating chronic pain. This goes back about 9 years. I haven't got any newer data on this, but only 15% of primary care providers feel comfortable treating pain. We know that 23% of academic primary care educators, so clinicians who are teaching our future generation, 23% feel knowledgeable about the subject that they're treating. So there's a huge knowledge deficit as well. And 41%, this is, I think, most stunning, don't even want to ask the question because we don't want to open up that problem issue of what are we going to do to manage it, and certainly try to avoid it. And that's why we get it on the way out the door. You know, your hand's on the doorknob. Oh, by the way, doc, what about my back pain? And to catch you at the way out the door, because we really try to avoid that question. From the patient's experience, it's a journey. Starts with, oh, you got a headache, can take some acetaminophen, it'll go away. Well, it doesn't go away. Or your back sprain will clear up, or whatever the general condition that the patients may present with. The treatments don't work. Their expectations are not met to get relief, and we may set unrealistic expectations. This produces pessimism. This generates anger. Anger typically not directly directed against the person prescribing the medications. So we get the real soft, sweet side of the patient. And this is why talking with your clinical staff, your schedulers and others about what's the patient's attitude and how did they respond to rescheduling or whatever. Because that anger is carefully not directed against the hand that feeds them. And then the isolation that occurs as a result of the loss of job, loss of a cohort of friends from the job, loss of relations within their family, loss of recreational activities. And then the key other aspect I want to highlight is isolation from the healthcare system, which has placed these folks often in the category of leprosy, where the last thing in the world we want to do is have them in our clinic, and we can't wait to get them out of the door. And this is a pervasive attitude. Of course, not for the TelePain network, folks, because you guys are fantastic at this, but in general, it is a significant problem. Some interesting work by Tanya Singer identifies this, and she's done phenomenal work. And Mark, if you want to comment on this a little after I've concluded some interesting aspects of her work, but with some functional MRI information and very clever experiments that she's devised that create the experience of social isolation and social exclusion. It's identified that the pain network and the reward network associated with social interactions are so overlapping they're difficult to disentangle. So, in other words, the experience of isolation from their loved ones, from their meaning and purpose in life through their job, and from we as clinicians, increases pain intensity and intensifies the very experience that we're attempting to modulate. Some of the things that we will experience in our interview and we want to elicit in the conversation is pain anticipation and catastrophizing. In other words, danger. If I do this, if I go see the physical therapist, my pain is going to be so bad I will never be able to go back to my life again, so I will not proceed with that. Avoidance of conflicts, avoidance of social interactions, and often avoidance of the psychological factors that are generating this because it's painful for these folks to do it, and they learn how to avoid this. If hurt equals harm, a nice question we can ask or even leave the visit with at the conclusion of our interview is that just because it hurts doesn't mean you're causing harm to your situation. But patients interpret hurt meaning harm. It's the alarm going off. That alarm is an alarm that signals through nociceptive networks in the brain that interprets it as tissue injury, and we have to do something about it. And therefore, activities and interactions are avoided. There's a sense of hopelessness. And when we say, there's nothing else I can do for you, and this often happens by our surgical colleagues when indeed they are done with surgery, but just saying there's nothing else I can do for you, come back when you have another problem that I can manage, really intensifies that isolation experience. And again, a very high prevalence of anxiety and PTSD in this population, not well recognized yet by pain specialties, and we're making every effort possible, and I think participating in our sessions here, you're beginning to recognize on a day-to-day basis how often uncontrolled anxiety and frequently PTSD is a factor. So a reminder, the adverse childhood events popularized by Bob Anda decades ago in the psychology and psychiatry fields has the history that we need to obtain. So this history we need to obtain about early life experience, adverse effects such as social and emotional abuse, contact sexual abuse, alcoholism, incarceration, family member who is chronically depressed, mentally ill, institutionalized, or actively suicidal, watching your mom or other loved ones, family members be treated violently, and emotional or physical neglect. These correlate to depression, suicide, multiple sexual partners, multiple STDs, smoking, alcoholism, impairments galore, disease and disability, social problems, and not yet published and studied, I'm looking to our fellows, chronic pain clearly correlates directly. This is something we see regularly in our practice, and I would strongly encourage exploring this in the context of your visit with your patient. Clarifying treatment expectations. I alluded to that earlier. Remind your patients in the course of the conversation, during the interview, at the wrap-up, not in the intake, but that we're seeking control, not cure. This is what Eloise Carr's focus groups told us. The patients at this point often recognize that they will not be cured, but to language it in a way that a cure or treatment and successful management of chronic pain means they will be able to control the pain. Pain intensity may not lessen, but functional limitations will decline substantially. In other words, function will improve mood, sleep, quality of life. Those domains that are now becoming regular parlance in pain outcome assessment, and helping patients locate meaning and purposefulness in their life, which definitely reflects quality of life. And if work provided meaning and purpose and they're no longer able to work, there are other ways to achieve that. All this hinges on patient self-engagement, and all this hinges on your skill as a clinician to be able to maintain that self-engagement. Harm reduction, again, is the focus. And we clarify treatment expectations right off the block by a pain care treatment agreement, an opiate agreement, a narcotics contract, lots of other terms. And you'll be learning more about this as our curriculum proceeds. Dr. Barak Gaster will be talking about how to engage with the pain care agreements. Joe Merrill just recently spoke about motivational interviewing and the like. So these themes are going to be interwoven as our 6-month series proceeds. This is a very small QI project that we did a few years back at the Center for Pain Relief upstairs. Hard to read, I'm sure. This is the pain intensity bars. This is pain interference. This is a PHQ-9. This is a GAD-7. This is a PHQ-4, which is the amalgam of these two. And this is the morphine equivalent dose. Going up is change relative to baseline, and going down is improvement relative to baseline, since these metrics are associated with lower numbers or better. And we broke these groups into 3 categories. The purple is everyone combined, and it really doesn't look like we did so well on pain in any of these groups. The blue is well-engaged patients. These were patients who, after the first interview, felt connected with the provider and felt that there was something that could be done for them, and that they left with hope and were compliant with the measures that we recommended that they pursue. They kept their appointments, is the bottom line, and they followed through on the referrals that we made. Minimally engaged, they kept their appointments with us, but did not keep appointments with many others. Not engaged, no shows, nothing was happening, and again, the aggregate group. So the blue group, so if we target patient engagement, we were able to reduce the pain intensity. This is about a 6-month follow-up interval. We reduced the pain intensity marginally, about 5% down, demonstrating once again that this is not our target. We should not expect to see pain intensity going down, and we ask a lot about how much does it hurt. We're going to be focusing on that. instead asking how much does pain interfere with your function. We did not have in this group a dramatic improvement in function. But our PHQ-9, dramatic improvement, almost 50%. Similarly with our anxiety score, our combined metric for mood distress, and our morphine equivalent dose was able to decline nearly 60% in this group without nudging the pain intensity, demonstrating in that buy-in by the patient will lead to improvement in the domains that we can be effective. Here I think was interesting is that we made people's function worse initially in those who are not engaged. In other words, raised hopes dashed them and function therefore followed poorly. So, Joe, I'm stealing this from you. Joe Merrill just came online. Hi, Joe. This is my, Joe does pain motivation in 101. This is a preliminary. I'm not smart enough to remember all the steps, but my dial-down version is this really the way you feel things should be going? Initial interview, appropriate to ask that. Change is possible. Change has happened, and then change can continue. The steps to move people forward in a motivational interviewing sequence. This requires therapeutic listening. We have to listen and be quiet. We know that physicians, I know nurse practitioners, PAs do a better job at this, but when timed physicians were able to not interrupt the answer to the question that they had asked beyond 11 seconds. So we ask a question, we get the answer, we interrupt already within 11 seconds. When told that they're going to be evaluated for improvement in that, they were able to increase it to 20 seconds. So we're terrible listeners, and we have a lot of time pressure. But listening is key, and advocating for the patient, meaning that, yes, I hear and understand this has been difficult for you. So you want to invoke the narrative story and offer open-ended questions so patients can fill us in those details, and then validate that particular experience as unique to them, acknowledging the bio, but certainly beginning the conversation on the psychosocial experience. Communicate usefully, which represents entering the patient's viewpoint, which is the definition of empathy, and supporting the process of care with realistic expectations. This will allow treatment engagement, and coaching and teaching will support that recovery. I've added this since my last talk because this question comes up again and again. In fact, I added this morning because the interns said, when do I do that? A case was presented. I'm going to be seeing a patient. He read the chart over. High-dose opiates, high-dose benzos, all the risks. When do I do the opioid and benzo talk? I recommend to the patient to the intern that chronic means it's going to be a long time frame. That establishing engagement is going to be critical for all else that follows. The opioid talk about dose reductions and risk and harm, the benzodiazepine talk about risk and harm, and finding out what else matters for the patient is going to be useful once you've got engagement, because they're not going to be opening up to you at all in that first visit, and the surest way for that patient to shut down completely and not disclose is to start threatening them with things that they don't understand about how they can possibly live without opioids. You can't get it all done on the first visit, and unless the patient is blue and apneic and so sedated that you feel it unsafe to leave your office, I recommend keep the program the same for the first visit, set the stage on the second visit, i.e. we'll be talking about what we can do to improve your medication management at the next follow-up visit, so they're a little bit ready for it. And then you throw the punch at the third visit, the tough conversation, after they believe that you're interested, after they recognize you're an advocate, and after they've established some willingness to commit to your care plan. So how do you do this? Tony Mariano, psychologist at the VA, says it beautifully. Listen as a dance. That means don't interrupt, follow your partner's cues. And Greg Vandekeef, a palliative care family medicine provider, independently said it's like a dance, but it's a jazz dance. And I don't think he knew Tony, so I'm going to say yes, I like the two together, because not only do you lead by following your partner's cues, but you've got to improvise it's not a stage dance. It's something that we have to build as we proceed. So, again, quick summary. I think it's clear. I recognize from our video connect, very familiar faces. I don't think much of this is new, but to those who are new to our network today, listen, empathize, validate, advocate, and support the patient, because then you will be able to follow through with the treatments that you're recommending. Assess pain function, mood, sleep, and risks at every encounter. I would say maybe not pain, unless the patient insists on asking about that. But that's going to include not only the intensity score, but the functional interference, mood scores such as the PHQ-4, sleep scores, evaluating risk through the opiate risk calculator and the morphine equivalent dose calculator, which we'll talk about in later sessions.